Welcome to another episode of Inside Your Miami Medicine. I'm your host, Ani Ford, the Dean and Chief Academic Officer of the University of Miami Leonard M. Miller School of Medicine. Our guest today is Dr. Rosie Curiel Cid, Chief of Cross-Cultural Neuropsychology and Cognitive Neuroscience at the Miller School of Medicine. She is a member of the Miller School Center for Cognitive Neuroscience and Aging, a designated center of excellence for Alzheimer's disease, and one of only 31 such centers in the nation. Dr. Curiel Cid is an internationally recognized authority on Alzheimer's detection, and her research is transforming how clinicians identify subtle cognitive changes and intervene earlier to slow the progression of this devastating disease. Dr. Curiel Cid, it's such a pleasure to have you with us today.
Oh, thank you. The pleasure is mine.
Thank you for accepting this invitation, because I think the topic we're about to tackle is so important and so and one that affects so many people that the audience is going to benefit from your amazing fund of knowledge. But before we get into the substance of our discussion, tell us a little bit about your journey to becoming the expert on Alzheimer's disease research and detection.
Oh, thank you. I am born at the University of Miami Hospital, I should say. So I'm a true Miamian through and through.
Okay.
And I've stuck around here because some of the most wonderful work that I've done in neuropsychology had to do with the research that I got into. So neuropsychology is the study of how the brain's structure and function and chemical state really affects behavior and emotions and the way people think.
But let me separate. How, growing up in Miami, how did you get interested in this particular line of research or in healthcare in general?
Well, in healthcare in general, I knew from a very young age that I wanted to work with people, and I wanted to work with people very closely and in a way that was very meaningful. And so I thought that psychology, clinical psychology, was very aligned with that possibility. And that's really what drew me into healthcare and into neuropsychology, because I found the brain to be so fascinating. It's an absolutely fascinating field. And so the specialty that I chose was working with people, but then also the people that have different diseases that affect their behavior. And so I found it to be very challenging and very fascinating. And so I specialty trained in neuropsychology. And then I came and I did my fellowship here at the University of Miami. And I bumped into a very special person who is my mentor and the director of the Center for Cognitive Neuroscience, David Lowenstein. And Dr. Lowenstein was, at the time, internationally known for developing novel cognitive tests. And he had developed one that I was very interested in using in the clinic. And I said, hey, Dr. Lowenstein, that test you developed, it's so interesting to me. Would you mind if I use it clinically? And he said, I think it's in a drawer somewhere here. I can dust it off and let's see what happens. And so I integrated this into our memory disorders clinic. And I found that the test was so clinically useful. I actually found that some of the performance was superior to the other tests that were commonly used in older adults. And that's what led to us exploring a database that got us the first preliminary data to write our and launch our research program.
That's great. And I'm going to get to that. But was there any particular incident or experience that directed you towards studying Alzheimer's in particular?
Well, I did happen to experience Alzheimer's at that point, not directly in my family. Ultimately, I did have my father who experienced dementia as a result of multiple medical complications in his life. And so that, of course, accelerated my desire to learn much more about the disease state itself. And as you said in the beginning so astutely, dementia and Alzheimer's disease is something that has touched or will touch almost every family. And it's very important that we learn more about it.
So tell the audience a little bit about the prevalence of Alzheimer's disease. And also, how many new cases are we diagnosing every year?
Yeah, so it's a rapidly growing in its prevalence. Right now, the numbers show in 2025 that we have over 7 million Americans living with Alzheimer's disease. But if we add to that, there's another 5 to 7 million of people living with the prodrome of Alzheimer's disease, which is mild cognitive impairment. And so this is the projections are staggering in terms of how many older adults are going to be living with cognitive impairment and or ultimately dementia in this country and in the world. This is a global problem. Once upon a time, post-World War, there was love in the air. The baby boomers came around and they've just started to turn 65 in 2011. So there's a aging of the world's population. But with that aging comes risk for diseases, and particularly diseases of the aging brain like Alzheimer's disease. And so the prevalence is growing, Miami in particular being affected, Miami-Dade County.
And I'm going to get to Miami-Dade, but so when we talk about 7 million people being affected by Alzheimer's, that does not include people with dementia or other types of dementias, frontotemporal dementia, for instance, or are we lumping them all together?
Well, mostly, we talk about Alzheimer's a lot because it's the one that we know the most of. It's been most researched, and neuropathologically, Alzheimer's disease pathology is most common compared to other pathologies. But we are, in terms of lumping people together, it is Alzheimer's disease and related disorders. So altogether, about 7 million people with Alzheimer's disease and related disorders.
And you mentioned Miami-Dade, and so please tell the audience why the prevalence is so much greater in Miami-Dade, and you've been postulated why, the causes, the potential reasons.
So Miami-Dade is one of the 3 top sites in the country for Alzheimer's disease prevalence. In part, we have a large aging population in Florida. It's usually historically the retirement state, but there are a lot of people from a lot of different places. There's a lot of heterogeneity here, a lot of people from groups like Hispanics and Black and African American people who we know are disproportionately at risk for Alzheimer's disease and related dementias. And that might play a role in terms of the prevalence. There's because of the population that we serve.
Is there an underlying reason why certain groups are predisposed to developing it more so than others?
It is a complex interplay of things, so complex that we're trying to understand now. These groups are also predisposed to other comorbidities. There is more cerebrovascular disease. There's more diabetes, other comorbidities that could accelerate brain disease, and so that's one factor. The other factor, are more cultural in nature, and the way people live their lives affects their, disease prevalence as well. And so whether or not there's more obesity or there's more sedentary behaviors or more stress and trauma related to immigration or less access to health care, all of these things, kind of work together.
So they all intersect somehow to do this. And of course, the fact that people are living longer, so they are more predisposed to developing signs of those diseases. Now, you alluded to the fact that there are millions of people who are living with early signs. What are some of those early signs?
So there are millions of people that are living with early signs that are measurable. And there are millions of people that are living with disease pathology growing that don't have evident signs. But the very early signs could include things like having trouble multitasking in the day-to-day, and someone who perhaps could do 3 or 4 things at the time needs to slow down. Sometimes people report that they lose the course of a conversation or that words don't come to them as easily. And that's pretty frustrating for people that are usually, highly verbal and that really want to express themselves. Sometimes it could be very mild forgetfulness, but people forget where they lose their keys or where they put their wallet. And these sorts of subtle, very inconsistent things that start to occur.
So, then this is a complaint that I hear commonly from so many other people, especially as they get older. Is there a certain pattern that, say, families, friends, or clinicians should be paying attention to that would make those early signs more significant? Because if it happens once or twice, should people start panicking and then run to their internist and say, "Oh, I have early signs of Alzheimer's," or is there something more substantive that they should be relying on to say, this is not normal?
For sure. I think that as people age, their brain ages just like any other organ, and there are changes that come that are normal parts of aging that sometimes look very similar to what I just reported, a little more forgetfulness or a little more trouble expressing oneself. And that could be normal part of aging. However, one of the key words is consistent. If these things start to occur more consistently, if there's not any other stressor that could account for it, when people are in high emotional distress, they're not at their best. And if they're depressed, they're not at their best. They're very anxious. So you also have to look at the person's symptoms in the context of their life. So if it's something that's rather consistent, then yes, these symptoms should be taken very seriously.
So tell us what's happening in the brain, if you can. If you take a small window into the brain, what's happening as those changes begin to manifest themselves?
So if a person is at risk for neurodegenerative disease, at risk for a disease like Alzheimer's, there are different pathological chemical things, structural, functional chemical things that start to happen in their brain up to 2 decades before they show any symptoms. This could be the accumulation of beta amyloid, for example, that leads to plaque formation. It could be neurofibrillary tangles, where the neurons and tau proteins start to tangle up. And these are very hallmark features of the brain, and they cause trouble with the neuronal signaling. Other things start to happen in that cascade. There's inflammation, there's oxidative stress, and ultimately the neurons begin to have trouble speaking to each other and die.
So it's important to pick up on those changes early on. So if the manifestation is some cognitive decline, so as soon as we begin to sense this, which speaks to your point, as soon as we start seeing the changes in behavior, we need to intervene to get those neurons to start talking together if we have the right treatment approaches. Is that correct?
Early intervention, I think, is critical here, because it really, there's so much going on in the field right now that early intervention, not only when one sees the clinical symptoms, but importantly, when that clinical symptom is paired to a biomarker. And if those two are linked up and we can get a risk profile that is more meaningful, then that early intervention could mean so many positive things for that individual.
And to that end, how early can we actually begin to detect these putative signs of cognitive decline or early Alzheimer's? Should we start looking for them at 30, 40, 50? What do it tell us?
Well, much earlier, for sure, much earlier than the dementia stage, which is when we're catching most cases now. When
What age is that?
Usually in people's 70s, and when a person is experiencing, kind of real loss of independence. That's when we're catching most cases now, outside of specialty centers. In a specialty center, like our memory disorders clinic at UN, Dr. Crocco and her team, we can pick up on symptoms during what's called the pre-MCI stage. This is before a person even develops the prodrome, which is mild cognitive impairment. During that pre-MCI stage, a person could be experiencing very, very subtle cognitive changes and have a positive biomarker. And so then that's the person that is optimal to follow. This can happen usually, sometimes in early to mid 60s.
Got it. So MCI is mild cognitive impairment, just trying to be
Mild
cognitive impairment. So that's what we're looking for. That's that's when we have a chance to perhaps intervene and arrest, slow down.
Yeah, well, research is moving a little earlier than even mild cognitive impairment into that pre-mild cognitive impairment stage.
So tell me, one of the common themes is that perhaps loneliness and solitude, isolation may contribute to the disease. Is that true? And in that case, what do you do about it?
Yes, we have found that that's true. And, in terms of the modifiable risk factors for the development of dementia, social isolation is a major one because individuals that isolate don't have as much enrichment. They don't have as many inputs. And as a result, there's an impoverishment of processing of information. There's an impoverishment of opportunities to experience joy or to learn something new. And so isolation is something that we, I think, as a society really need to pay attention to because so many of our older adults are living on their own and maybe not sharing the social experiences that can enrich their brain.
So not enough brain stimulation. Is that why some people say doing crossword puzzles and things like that stimulate the brain and what's Oku waves, some of those mathematical games? Is that why those things seem to make a difference?
Well, for sure, brain stimulation that is challenging, that is novel, is very important. So not the same old New York Times crossword puzzles, but something new, learning a new language, learning how to play an instrument, learning how to dance, doing something that's novel and challenging helps to neurons to branch out and grow. Yes.
First,
Even in older adult years. See, when I was in graduate school, they said things like, oh, you have a limited amount of neurons, and once they're gone, bye-bye. Now we know that that's not the case, that plasticity is very real, and that it can happen even in older adults.
so I should start learning a new language.
Sure.
I love it. Um, so what are some of the biggest misconceptions regarding memory loss in normal aging versus early signs of Alzheimer's disease?
Yes. I think one of the biggest misconceptions that I bump into a lot is that memory loss is normal as one ages, that it's a normal part of aging to be forgetful or to have to rely on other people to manage your affairs. That's not necessarily true. I'm very privileged to see people well into their 80s and into their 90s handling all of their affairs, thinking things through very carefully, problem solving, being a source of wisdom and assistance to their loved ones and to their community. And so I'm very privileged to see the very healthy side of cognitive aging. And so it's a misconception to think that it's okay, leave grandma alone. She's growing older now, and it happens to everyone.
In your practice, is this more of an anomaly to see an 80-year-old fully in charge of all of their executive function as opposed to others who are more dependent? Or is it more cultural, for instance?
Yes. Well, when, the base rate of people that come into a memory disorders clinic, of course, come in because they need some help and they want an evaluation because they've noticed some trouble. But I get to do a lot of work in the community, and I get to see a lot of people thriving in the community. And it's not very, very common, but I see it in every community where there are people well into their 80s. In fact, I have a funny story. There was a participant, and she said, oh, Dr. Rosie, I will come to your study, but on one condition. And I said, okay. And she said, you got to tell me where the best happy hours are on the Miami River. And I said, oh, okay. So she and her new partner were 80 and 92.
Wow.
Yes. And they were, came down to the medical school campus and enjoying life.
I love it. In that same context, so we often hear about or advertisements for over-the-counter medications that will enhance memory, that will prevent memory loss. First of all, do they work and are they useful in terms of trying to slow down Alzheimer's?
I don't think there's a lot of evidence to show that these supplements and memory enhancing drugs are really that potent. They certainly don't have the evidence that exercise has, or that good quality sleep has, or that managing mental health conditions, for example, in terms of optimizing one's cognitive function. And there's a lot that one can do and should do before they even consider spending money on a supplement.
And you alluded to some of them. So tell the audience what it should be: exercise, stimulating the brain, learning a new language, ballroom dancing if you've never danced before. What else would you suggest?
Well, everything you just mentioned is very important, but there are other things that are important. So, for example, correcting your hearing loss is very important because it accounts for a good percent, about 3% of the variance of developing dementia later in life if a person has problems with hearing loss. The socialization aspect, that's one thing that's critical, is to get involved with your community, with your neighbors, and do things for others. Managing mental health conditions, we had treatments that really work for depression, for anxiety. And so neglecting mental health is a sure way to have brain deterioration over time. And so these are all things that are critical for maintaining brain health as we age. Good sleep.
Those are very good suggestions. Now, let me shift a little bit to talk a little bit about some of your seminal work, because you and your team at the Center for Cognitive Neuroscience and Aging have developed a new cognitive test that's more sensitive than the other widely used assessments for detecting Alzheimer's. And you mentioned that at the beginning. So tell us about that test and what makes it so different and more precise, and what exactly does it measure?
Thanks for asking. So we developed what are known as cognitive stress tests. They challenge the cognitive system to be able to pick up on very subtle changes that typical memory tests and typical cognitive tests don't pick up on. And so what happens is that an individual may make an error that is very salient to the error that people with Alzheimer's disease would make. In the past, we gave these big batteries tapping different domains of cognition. And while that's very important, during the discovery phase of what a diagnosis may be, at the end of the day, we need to have cognitive tests that link to biomarkers so that we know that this is an Alzheimer's disease specific problem, and when that problem begins to happen, and how much does that cognitive deficit track disease over time or help us to prognosticate better. And so our cognitive challenge tests are very useful, have been found to be very useful. Other people across the world have taken interest. It's been translated into 8 different languages, and it's been validated in different cohorts, not only in Alzheimer's disease, but also in multiple sclerosis, in pre-manifest Huntington's disease. And so the idea is to be able to have a clinical marker pair up with a biological marker so that we can catch people earlier and track them better over time.
Okay, so which came first, the chicken or the egg? Do you get the biochemical test first, or is it informed by the detection of those subtle changes in the cognitive test that you've designed? Is that what's the proper sequence?
The proper thing to measure is in a contiguous way. However, really, it's very inexpensive. It's not invasive at all. It's less invasive than even a blood draw, and it's pretty scalable. So if you can pick up that the person has a cognitive deficit, you may think, okay, maybe it's time to refer them for an amyloid PET scan. If they're making this particular deficit, then maybe it's time for them to get that blood test. And so systematically, I think that we can start at the least invasive and most cost-effective and most easy to measure way, which is a cognitive deficit, and then move on to acquiring the confirmatory blood biomarker or neuroimaging marker.
Okay, so all right, so you mentioned 2 things: the blood biomarkers and the amyloid PET scan. What are biomarkers, and which ones do you recommend, and in what sequence?
So biomarker is a measure of a change that's happening in the brain or as a result of changes in the brain and the periphery.
That's a blood test.
For example, a blood test. But a biomarker could be measuring the structure of the brain, measuring the function of the brain, or measuring the chemical state of the brain. And so in Alzheimer's disease research, we have biomarkers that are neuroimaging based, MRI, and very importantly, amyloid PET imaging, tau imaging. And we also can now measure what we used to measure in the cerebrospinal fluid. We can measure it in the periphery because of advanced technology. So we can get a simple blood draw from people and be able to measure the presence of pathological tau protein that has, become available to measure in the periphery. And it's important because it's really revolutionizing the field, what we're learning about these blood-based biomarkers and how they can help us detect disease.
Well, so that's fantastic. Now, we talked about the importance of early detection in doing the cognitive testing and linking that to the biomarkers, whether PET, amyloid PET scan or the biochemical tau and amyloid levels. But so what? We detect them. Do we have a treatment that can interrupt the cascade leading to Alzheimer's?
Right now, we have 2 new FDA-approved treatments that target amyloid, and more than 100 treatments in the pipeline that are currently being developed and tested in phase 1, 2, and 3 clinical trials. These 2 new FDA-approved treatments help to attenuate the accumulation of beta amyloid pathology in the brain. So I remember very recently that question, so what? Do we actually have, so what if you know early? Do you actually have a treatment that can stop this disease or that can lay down the speed bumps of the disease? And unfortunately, I would say no. We had cholinesterase inhibitors and NMDA receptors antagonist, but now it's no longer inconsequential. I tell my primary care colleagues, my family medicine colleagues, it is no longer inconsequential to not detect this disease early, because if you're going to be eligible, let's say for these new anti-amyloid therapies, that's going to happen during a very critical window period, during the mild cognitive impairment phase or very early dementia phase. So it's very important to be able to identify someone during that critical window where then they can choose to participate perhaps in one of these.
We'd seen some studies that reported that the efficacy of some of these FDA-approved drugs were in the neighborhood of 20, 30%. Is that accurate, or is there evidence that we are developing more potent drugs to retard the progression of disease?
Yeah, so it's an advancement for sure. We need to do a lot better. There's a slowing of the progression, but there isn't a stopping of the progression. And that slowing of the progression of the accumulation of beta amyloid, for example, isn't necessarily resulting in a person having a better quality of life or in symptom improvement. So many times the patient and their loved one don't necessarily feel better, don't necessarily feel more functional, but hopefully there could be a longer period of very mild symptoms.
Basically, you alluded to the fact that early detection is important, so the primary care physician has to play a critical role in that process, as well as perhaps some family members. And do you sense that there are some barriers to primary care physicians or the close relatives being able to point the individual or refer the individual for early intervention?
Absolutely. There's so many barriers. The primary care physician is the frontliner. They are the ones who more often than not are receiving those first early complaints about a person being more forgetful or having a little more trouble. Or perhaps it's the family member that will complain to the doctor, he keeps repeating himself, or I find his memory is not what it used to be. And these barriers that the primary care physician encounters are numerous. They, first and foremost, don't really have the knowledge of mild cognitive impairment and exactly what to look for or how to evaluate it carefully. They don't have the tools accessible to them. They may not know that they're blood-based biomarkers that they could order or that they're cognitive challenge tests that they can integrate into their practice. They don't have the tools. They don't necessarily have the knowledge. And of course, there's a time scarcity there where, they're seeing so many patients. To really stop and evaluate someone is hard to do. And so oftentimes they have to refer them to a specialist, but that could be complicated because it's hard to get in. There are just so many specialists in town. And so a lot of times symptoms go either ignored or underdiagnosed. There are some estimates that say that about 90% of cases of MCI go completely undiagnosed in a primary care setting. 90%. And so there's so much work to do with our primary care colleagues, and we intend to do that work.
Especially to deal with the population Miami-Dade that's so heavily affected. And as we get ready to close, you are leading a project that's looking at deep phenotyping of African Americans who are at risk for Alzheimer's. What inspired this focus? And also tell us, in a nutshell, why focusing on one particular demographic can inform disease processes in the rest of the, the community in Miami-Dade for that, for instance, or the rest of the country.
Well, African Americans are about 1.5 times more likely to have Alzheimer's disease and related dementia.
For all the reasons you just alluded to before.
For all the reasons previously mentioned. And yet, this is a group of individuals in our country that is growing. The older adult population is growing, but they're really underrepresented in research. So we do not know enough about how Alzheimer's disease and other dementias really present and progress in this population. And here we are in Miami with sitting in a neighborhood that's predominantly African American, and they're not coming into our clinics, our specialty clinics, and they're not participating in research at the level that they should be represented. And so we said, this needs to end. So we designed a study that is it's a deep phenotyping with imaging, blood-based biomarkers, annual follow-ups, cognitive challenge test evaluations, full deep work of genetic, etc. Analyses, and we go to them. So one thing that's very special about this study is that we don't expect them to come to us. We will go to them. So it implements a home-based assessment models. We go into their communities. And I'm very proud of the study. We exceeded recruitment targets already before, the recruitment period ended. We're learning a lot. And the second part of your question is, why is it really important to learn about a particular community that's at disproportionate risk? Well, because we can learn more, not only about the biology of those individuals that are at disproportionate risk, but what are those other factors that could be influencing disease? What are the other comorbidities? What are the cultural influences? So if you learn a lot about a particular group, you do have the opportunity to extrapolate some of that knowledge into other individuals that are affected by the disease at a different rate.
So understanding the underpinnings of Alzheimer's in that particular population is really going to help us come up with more optimal therapies to treat the broader population. So that's the take-home message.
That's the take-home message.
Dr. Rosie Curiel Cid, I could go on. There's so many other questions I wanted to ask you, but I'm afraid that our time is up. But let me say, it's been wonderful to talk to you, to learn so much about your work and how it's potentially transforming our understanding and approach to the management of this really vexing disease that we know as Alzheimer's disease. So we are looking forward to your discoveries and interventions because that's bringing a beacon of hope to the citizen of Miami, Florida, or of South Florida, and in particular Miami-Dade. So thank you for your work.
Thank you.
And this has been another episode of Inside Your Miami Medicine. See you next time.